Okay, great. I think we'll get started, and then I know more people are still joining us and can join as we go. Good afternoon, everyone. Welcome to the Atlantic Regional Roundtable on flexible models of care for the clinical management of opioid use disorder. I'd like to start by acknowledging that I'm joining you from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, and we are all treaty people. I also want to recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched this part of Mi'kma'ki that I'm in, known as Nova Scotia, for over 400 years. This is an Atlantic regional session, so I would also like to acknowledge the traditional ancestral lands across what is colonially known as the Atlantic provinces, New Brunswick, Newfoundland, and Labrador, Nova Scotia, and Prince Edward Island, that have been cared for by Indigenous people since time immemorial. And this is especially important to reflect on, given the focus of our session today, as we know that harms associated with opioid use and other substance use disproportionately affects Indigenous peoples and communities, in large part due to the ongoing legacies of settler colonialism. And I invite you to take a moment to reflect on where you're joining from today. My name's Tommy Brothers, and I was asked to moderate today's session. I'm an internist and addiction medicine physician based in Halifax. I'm currently a general internal medicine fellow at Dalhousie University and a PhD student in epidemiology and public health at University College London in the UK. I'm an opioid agonist treatment provider myself, and I'm also the Atlantic Region clinical lead for the 2023 update of the CRISM National Opioid Use Disorder Guidelines. We have a wonderful lineup of speakers and panelists today, and I know we're in for a productive and thought-provoking session. Today's session is primarily for clinicians, and it'll challenge us to think creatively about how to provide better opioid use disorder care, and specifically how we can use flexible approaches to improve engagement, retention, and outcomes for people with opioid use disorder. This webinar is part of a suite of knowledge translation activities for the OPTIMA trial, all of which focus on expanding flexible models of care for opioid use disorder. There are several events aimed at communicating the trial's findings, both for clinical and community audiences. In addition to the regional roundtables like this one, the OPTIMA team will be hosting community workshops where they'll present the findings to people with lived and living experience of opioid use disorder and opioid agonist treatment, their community partners. Plans are also underway to host a national panel discussion with a range of stakeholders, including clinicians and people with lived and living experience, to better understand how to optimize engagement and retention in treatment for people with opioid use disorder. In today's session, we'll start with a brief presentation about the OPTIMA trial and key findings, and then the second part of our session will be a panel discussion with an opportunity for audience questions. First, a few housekeeping items. Please keep your camera and microphone off during the session. This session is being recorded and will be posted on the CRISM YouTube page. The link to the recording will be shared after the event. As we go, please enter questions into the chat box, which we will be moderating throughout the session. We have dedicated time at the end to take audience questions. If we don't get to your question, some of the panelists will be staying online for a few minutes afterwards if there's still some burning questions and discussion. And there is a pre and post evaluation survey, which enters you into a draw for two $50 gift cards to your choice of Starbucks, Indigo, or Amazon. And your feedback is really important. It helps improve this session as well as plan for future knowledge translation and capacity building activities. So now I'd like to introduce Dr. Sherry Stewart to provide us with an overview of the OPTIMA trial and its key findings. Sherry H. Stewart is a Tier 1 Canada Research Chair in Addictions and Mental Health and a professor in the departments of Psychiatry, Psychology, and Neuroscience and Community Health and Epidemiology at Dalhousie University. Dr. Stewart is a Fellow of the Royal Society of Canada and the Canadian Academy of Health Sciences. She is respected internationally for her research on psychosocial and motivational factors contributing to emotional disorders, addictive disorders, and their co-occurrence. She's also the nominated principal investigator for the New Atlantic node of the CRISM network. Welcome and thank you, Dr. Stewart, and I'll hand it over to you.
Thank you very much, Dr. Brothers. I'll get you to just move on to the next slide. So we've gone through the objectives for today. So what I'm going to be presenting is a very high-level overview, quick overview of the main findings of the OPTIMA trial. I'm going to go on to the next slide. I don't have any conflicts of interest to declare in relation to this work today. I actually wasn't one of the NPIs on the OPTIMA trial, the primary trial, but I was principal investigator on one of the ancillary studies. So that's my relation to this project. So in terms of setting the stage, as most of the audience is clinicians here, you'll be well aware that opioid agonist therapy, or OUD, remains the standard of care for the treatment of opioid use disorder. And that includes for the treatment of prescription type opioid users. But there are lots of different barriers to access and to keeping people on OAT, including the strict supervision requirements for methadone. So the relative safety of buprenorphine naloxone allows for a more flexible model of care where people can take home their doses much earlier and for example, but that's been poorly studied, buprenorphine naloxone in relation to methadone in the context of prescription type opioid use. So that was the purpose of the OPTIMA trial. So let's move on to the next slide. So the goal of the trial was to compare the effectiveness of buprenorphine naloxone and methadone as two different models of care in real-life clinical practice settings in individuals who had prescription-type opioid use disorder. And it was a multi-site study. You can see the different sites across Canada here as part of CRISM. The design was a two-arm, open-label, as I mentioned, multi-center, pragmatic randomized controlled trial. So a pragmatic trial just means that it's allowing for flexible dosing, like in real life settings, and use testing in real life clinical practice settings. Now, the primary outcome of this trial was looking at the ability of the two drugs to suppress opioid use in people with prescription opioid use disorder. And it's called a non-inferiority trial, meaning they were just trying to establish whether buprenorphine naloxone could suppress opioid use just as well as the more standard methadone or more well-established methadone. Participants had study visits every 2 weeks, including urine drug screens, because that's how they defined the suppression of opioid use for the 24-week intervention period. And here's the description of the dosing for those interested in the dosing. That's all given on the left-hand side, showing the initiation doses for each model of care and how they were increased to what maximal dose. And I think the really important part here is to notice the difference that in buprenorphine naloxone, participants got carries after 2 weeks of initiating their medication, whereas we didn't see that until 2 to 3 months after initiation in methadone. I'll go on to the next slide. Okay, the inclusion criteria were that they were adults, they were diagnosed with an opioid use disorder that was prescription type. It could be either illicit or licit prescription type opioid use disorder. And that included fentanyl. They had to accept being randomized to buprenorphine naloxone or methadone. And there were a number of exclusion criteria. So unstable psychiatric or medical conditions, if they had a pain condition that required treatment with opioids, if heroin was the most frequent opioid because the focus was on prescription type opioid use disorder, if they'd been enrolled in OIT 30 days prior to the onset of the study, a history of severe reactions to either of the primary medications, or if they were a pregnant and breastfeeding woman or planning to conceive. On to the next slide. 272 participants were enrolled on average in their later 30s. About 2/3 were men. You can see over on the left-hand side that about 3/4 of those on buprenorphine naloxone actually received take-home doses, whereas only about 1/3 in the methadone eventually got take-home carries privileges. And you can see there's a huge difference in the number of days of treatment before they received their take-home dosing. You can see in the upper right the mean maximum dose of each medication. And something to note that we'll go over in more detail later is that there was more switching in the buprenorphine naloxone than methadone groups. So a greater proportion of people in buprenorphine naloxone switched to another medication, another OAT, and often that was buprenorphine naloxone to methadone. Next slide, please. Dr. Brothers, yeah, thank you. Okay, so this is the main outcome on the left-hand side. So this trial did establish the proportion of opioid-free urine screens across the weeks of treatment, and it's higher in buprenorphine naloxone than methadone. In fact, in many of they did a number of different sensitivity analyses, and in almost all of them, buprenorphine outperformed methadone. So it's at least establishing non-inferiority and likely superiority of buprenorphine naloxone in suppressing opioid use. In terms of retention, I already showed you that there was a lower retention rate with higher switching, but also, higher going off the medication in buprenorphine naloxone than in methadone. But if you look over on the right of the retention data, you can see once they looked at retention on any OAT, that group difference disappeared. So when they were, looking at retention, if somebody switched to another medication, as long as they were still on an OAT, you didn't see any difference in the two conditions. And then over on the right-hand side, there was no difference in serious adverse events. The most common drug-related adverse events reported in the trial, and there was fairly low frequency of those, was withdrawal symptoms, overdose, and a hypogonadism. On to the next slide, please. Now, this is a summary of, there were a number of ancillary studies that were embedded within the OPTIMA trial. And this shows the outcomes of those, which were all quite positive, in fact. So you can see health-related quality of life increased in both groups equally. Cravings decreased in both conditions, with greater craving reduction from buprenorphine naloxone, which is consistent with the urine screen outcomes on the main trial. Depressive symptoms decreased equally in both groups. Patient satisfaction was good in both conditions. Pain decreased in both groups. In fact, pain severity decreased more in methadone than it did in buprenorphine naloxone, but the pain-related interference reductions were similar. And in terms of sexual functioning, we saw improvements from baseline, from before they went on their buprenorphine naloxone. And then we saw reductions, so impairments in sexual function on methadone, particularly in women. On to the next slide. So what are the implications for practice? So this more flexible model that's allowed by buprenorphine naloxone relative to methadone, we see that it's safe, we see it's inferior to methadone compared in terms of suppressing opioid use. We see there's a decreased retention in the assigned OAT in buprenorphine naloxone, but a similar retention when you look at remaining on any OAT. So this suggests clinically that clinicians should be considering early take-home doses when they're clinically indicated. In other words, thinking about buprenorphine naloxone and allowing for that kind of flexible model of care, and considering a step care strategy. So beginning with buprenorphine naloxone in many instances, and then on to methadone if it's needed, if that switch is needed. On to the next slide. And we recognize that reaching optimal outcomes can be quite difficult in real world settings. And this trial really suggests that we should be offering patient-centered care that involves proactive discussions between clinicians and their clients who have opioid use disorder on how to make the best treatment decisions given their individual needs. So for example, if a client has a need to not be coming into the clinic every day, buprenorphine naloxone might be a better option for them, just as an example. And we need a lot more research on adjunct interventions, alternative models of care, and other strategies to improve outcomes further. Next slide. And I just want to acknowledge all the people involved. Over on the right-hand side, we have the main, the NPIs of the OPTIMA trial. The lead principal investigator was Dr. Jutras Aswad in Montreal. And then over on the left-hand side, we want to acknowledge all the participants, the people with lived experience that were advisors in CRISM and OPTIMA, the research coordinators and all the research team members at all the various sites where this research was conducted, the node managers, and the statistical analysts at UDM, Benoit Mass, and IRCA, and the data safety and monitoring board. And then, of course, the steering committee, I have that over on the right-hand side as well. So on to the next slide. So I'll open it up for questions.
Hi, Sherry. I'm just curious if all of the participants were managed in a rural or in an urban setting.
That's a really good point. The majority of the sites were more urban settings, just I think for practical matters about getting the numbers, but there were no rural sites, but there were like less centralized sites like Sudbury, for example, but I think there were more difficulties in recruitment in those sites.
We do have a few more minutes for questions for Sherry before we move on to the panel. Bruce, I see your hand up. Do you have a question for Dr. Stewart?
Yeah, I do. Thanks. Sherry, were there many patients on fentanyl? Prescription?
I don't know the answer to that. I don't know if anybody, I know that was allowable for the inclusion, but I don't recall the stats on how many were on fentanyl.
Okay, because that has had big implications towards practice care, right? Because what they're doing in BC and Ontario towards moving towards other drugs to treat fentanyl.
Yeah, I would have to look back to the paper because I don't recall that information.
No, I'll have a look. I'll satisfy myself. Thank you.
Yeah.
And Bruce, I think there is a secondary analysis paper published in Addiction with Dr. Socius as the lead author. Maybe I could share the link where they looked at whether fentanyl use in the trial affected people's outcomes. And so far that analysis showed that it didn't, that people who had urine drug screens positive for fentanyl had similar outcomes on methadone or buprenorphine models of care compared to people who didn't.
Good. Okay, thank you.
Thank you.
If you could link, that'd be great. Thanks.
Sure, yeah. And I see Dr. Allen's hand up. Maureen, do you have a question?
I'm just curious whether the groups were looked at from whether or not they developed their opiate use disorder from the medical use of opiates, or they developed the opiate from the non-medical use, and was there any differences in those populations? Because that's what I always find clinically so much more challenging when we're looking at populations who develop opiate use disorder from the medical use. I'm just curious if there was any. I saw there was a accelerated study just looking at pain, but just curious about that.
Yes, so I was at the knowledge translation event where they released all the, the findings of the ancillary studies as well, and I don't recall that coming up. I do remember that people who were receiving opioid for the treatment of a pain condition, that they were excluded. However, you could still have like comorbid pain conditions where that wasn't the primary treatment. And certainly we saw reductions in pain with both treatments, but I don't have an answer to your question. I don't know if anybody's done that comparison. I don't know if there's anybody else on the webinar who might have that information. I don't believe there was a sensitivity analysis done in the main trial that I recall answering that question. So it's also, it's worth noting, if that's something of interest to you and you have time for research, I think that the NPIs are quite open to having requests for access to the data to answer questions like that. Dr.
Yeah,
Webster?
that's a great point.
Yeah, thank you. Sorry, I don't have an answer to that, but I've got another question if you want.
Yeah.
Just based on the OPTIMA trial, as well as the real world experience of yourself and other people on the webinar, when using buprenorphine and naloxone, what's the general approach in terms of initiating carry doses? What are people doing, and what would be recommended based on this data? So people are getting stabilized, and how quickly are you starting to give carries, and are you doing it in sort of a serial fashion, or are you going right to weekly carries?
Yeah,
I
so
think that
I mean, I
will
think,
be a topic of discussion in the panel in our next section. So
Okay.
maybe we can put a pin in that and circle back to it at the end if we haven't gotten specific enough, if that's okay.
Yeah, no, that's
yeah,
perfect.
and
Thank you.
maybe at that time, if we wanted to, we could return to that slide to show how it was done in this trial. Like there was a lot of flexibility, but there was a general approach to, you know, after 2 weeks, they could get 1 week of take home in buprenorphine and naloxone. And then after a certain amount of time, then they got, you know, 2 weeks worth. So that was kind of, that piece was again flexible, but there was some standardization to it.
That's great.
But I think what people's experiences are in this call will be one of the topics of discussion.
All right. I look forward to the panel. Thank you.
Yeah, thanks very much, Sherry, for sharing that overview of the OPTIMA trial and digging a little deeper on some of those questions. I do want to move on now to the panel discussion portion, and it's my pleasure to introduce the panelists. We have an amazing group today from several disciplines, zooming in from New Brunswick, Newfoundland, and Nova Scotia. And I'll ask to start each of you to share your name, your role, and the lens or perspective that you feel you're bringing to your work in this discussion today. Maybe Sara, Dr. Davidson, we could start with you.
Sure, thanks, Tommy. Hi, everybody. I recognize a bunch of names on this, so that's great to be connected again. So yeah, I'm Sara Davidson. I'm a family physician at the Fredericton Downtown Community Health Center, which even though Fredericton's a tiny little town, it's the capital, so it's our urban clinic. I love working there. It's a great team. From that, I had started a walk-in addiction medicine, trying to be rapid access and just seeing the significant harms related to intravenous drug use and crystal methamphetamine that a colleague and I, who's one of the panelists as well, Dan Pike, went in and applied when SUAP had come out with a call for clinics to help with safer supply options. So we started Riverstone Recovery Center, which is a 5-year pilot, and predominantly IOT is the focus of the SUAP part. I still do oral addiction medicine as well for both stimulants and for opiate use disorder. And so the lens I bring, geez, I guess from an IOT, I'm a bit biased towards some parts there. I'm on a group called Doctors for Decriminalization, and I'm helping Health Canada with discussions around safer opiate supply options. So bring a lot of interest there and bring a lot of clinical experience with rapid access.
Thanks very much, Sara. And Bruce, Dr. Hollett, would you like to go next? Introduce your name, your role, and the lens you bring to your work in this discussion.
Hi, everybody, and likewise, I see a lot of people I know or familiar with, so I say hello to all of them. I work through the Waterford Hospital, which is the only psychiatric referral hospital. And I'm working out of St. Clair's Mercy Hospital now with a clinic set up for chronic pain and addiction primarily. I've worked as an opioid provider, both for pain and for OUD therapy, as well as Suboxone for pain and for OUD therapy as well. I very familiar with the opioid agonist therapy, providing help throughout the province for the last 15 years or so. I'm getting long in the tooth, so I'm starting to cut down on a lot of the practice things that I've been doing and moving forward. My practice is purely referral only, as I have a subspecialist in geriatric addiction, chronic pain. It's a lens I'm looking after. It's a wide focus that I've great experience throughout Newfoundland, and was one of the people involved with trying up our opioid, our OP therapy within the province that has done exceptionally well into a hub and spoke type model. So I think that's all I.
Thanks very much, Bruce. Sharon MacKenzie, would you like to introduce yourself next?
Yes, thank you. My name's Sharon MacKenzie, and I'm a registered nurse, and I worked in the opiate recovery program with NS Health for 20 years, way back in 2004 when we had our very first pilot project or demonstration project, as we call it, when things were very rigid and wasn't on the national agenda, and you're trying to advocate and create programs, policy development, operating procedures, all those types of things. So was heavily involved in that in the eastern part of the zone in provincial Nova Scotia. Helped with the sort of developing the landscape there. For the last 2 years, I've kind of switched roles, and I am now a street nurse with the Ally Center. And we are very much a harm reduction based program. That now my role and my lens comes from constantly advocating and trying to connect people to primary health and services, and particularly OAT is a big part of my role in terms of trying to help people gain access. So I think I bring sort of, not that there's ever sides, but certainly see it from a different lens now in terms of trying to bring people to a program versus trying to find and bring, it's just a different role, I guess you'd say. So that's my lens.
That's great, Sharon. Thanks very much for joining us today and bringing all those different perspectives and experiences. And our fourth panel member is Dan Pike. Would you like to introduce yourself and your role and what perspective you're bringing to the discussion?
Yeah, most certainly. Thanks, Tommy. Happy to be here and share kind of my lens anyway. I'm a retail pharmacist. I have a couple locations in New Brunswick, one here in Fredericton, another one that just opened in St. John, both of which supply the medications for the IOT program. Sarah and I started Riverstone Recovery about 4 years ago now, so kind of wear two hats most days, but yeah, happy to be here and share any light with respect to the pharmacy end of things.
Thanks very much for joining us, Dan. So I will get the discussion started with a few prompting questions. As we heard from Dr. Stewart, the OPTIMA trial compared models of care for opioid use disorder. And one of the key findings was that take-home buprenorphine naloxone in a flexible treatment model was non-inferior to traditional treatment with daily observed dosing of methadone. And with this in mind, flexible models of care could improve treatment outcomes for patients with opioid use disorder. So I'd like to ask our panelists, when you think about flexibility in the care of people with opioid use disorder, what comes to mind, and how do you put this in practice? And anyone could take that first.
I'm happy to chime in to get the ball rolling. So definitely it's been a game changer having a lot more flexibility in terms of prescribing and what's allowable. And COVID actually helped with part of that as much as the OPTIMA trial as well. I think that all of us recognized how much danger a lot of people are in, and the quicker that we can respond and meet people where they are at, how essential that is. So it's lovely to have the OPTIMA trial to now be able to hang my hat on and go, see, this is non-inferior. And in fact, it's meeting a lot of people where they're at. So as I was mentioning in my little intro, that I've been doing walk-in sort of addiction medicine as long as I could. It was a group appointment model where people could just walk in over 2 different hours, 2 2-hour time slots during the week, and we could get them on treatment right away. Because when people are ready, that's when they really need to be met. Riverstone is similar in that we have staff that are here 7 days a week, so people can walk in off the street. We have a QR code. Anyway, I'm jumping to the punchlines of some of the end of the panel discussion about next steps. But essentially, my point is that being able to have the flexibility and the guidance that Suboxone, or sorry, buprenorphine naloxone is sort of safe and reasonable to have as carry doses has been a game changer for a lot of people. And I think it was Dr. Allen was asking about, was the study done in rural, like OPTIMA, rural versus urban folks? And as much as Fredericton is a big city, it's not really. We're in a rural province essentially, and a lot of the people that we provide care for, we do virtually in smaller rural settings. So it's been very important to have this as an option for people that are living rurally, because some people will get started on treatment and there's no way that they can get to the pharmacy every day. And so to be able to offer them the option of, as soon as they're starting and we've done an induction, we go to weekly carry home doses. The only instances that we might not do that right off the bat is if people are living outside in a tent setting that's volatile and where they might be exploited for their medications. And sometimes people are choosing to come in every day because they do find some connecting with cool pharmacists, and just that structure in their lives is really important. But we do give the option really quickly to have Suboxone. And again, some of the other opportunities that it's given us is, I remember on a Friday night, we were just finishing up our staff debrief at Riverstone and we got a desperate call. A family was bringing a daughter from Toronto. She'd been using fentanyl a whole bunch and she was going to be living with them on a farm, and they had intermittent internet access, but they just wanted to keep her alive. And we were able to call in an induction prescription that they were able to do with her that night with guidance from us. And then she was able to get weekly carries just to keep her out of the woods and to keep her alive. And so it'd be a lot scarier to say, yeah, let's have a whole bunch of methadone going out necessarily in that case, perhaps, or, you know, even Cadian or other options, but Suboxone just really has the safety profile that I feel very comfortable, and it lets us be able to respond really quickly whenever people are needing to get to a certain point of stability. So I'll let other people talk. I certainly have other points, but I'll let other people talk too.
Those are some really great examples, Sarah, talking about flexibility in patient preference and choice, flexibility in timing, in where people are living and their accessibility to pharmacies and medical clinics and that sort of thing. So it's wonderful to have those examples and think about how the evidence based on safety can support putting that into practice as well. Do other panelists have thoughts about what it means to be flexible in caring for people with opioid use disorder and putting it into practice?
I would just, it's Sharon here. I just like to kind of build on what Sarah already said. I mean, as a street nurse here, and you know, a lot of our programs, we are urban, we're mostly rural, but we have urban rural centers with limited sort of access to different infrastructure to make, you know, it's one thing to have a flexible program, but if you don't have, you know, like you say, the infrastructure to get to the pharmacy, like no buses running, no transport, no money, no housing. So, you know, sometimes the struggle can be that if someone presents to you at walk, we do everything here by walk-in. It's meeting people where they're at, but sometimes when you're trying to negotiate a program, if they're only open Monday to Friday and there's no evenings or weekends, you're really telling people, well, just hold off until Monday. I might be able to connect you Tuesday. And it's amazing, you know, like you said, Sarah, that, you know, with COVID, it was like, you know, hurry up and let's be creative. And we all got very creative, and it's been fantastic, all those changes. And we've really learned a lot. And I think we just need to continue to build on that. And sometimes we just don't have the, you know, we still have a lot of Monday to Friday services, whether it's private or, you know, the provincial health system or whatever the case may be. And I think that the flexibility really needs to, you know, that bottom line of harm reduction, it is meeting people where they are in that moment, because you kind of lose your audience if you can't, you know, kind of negotiate a plan in that moment. Then you might not see them for another week, and things could really deteriorate for that person in a very short time. So the timeliness and the flexibility is there, and kudos to all the pharmacists who I know have worked with pharmacists over the years that come in and just, you know, did some dosing for an hour for people that really needed it on a Sunday, because we didn't have a lot of those options back in the day, and we see that a lot, and a lot of commitment from a lot of people. But the flexibility needs to kind of align with some of the timing in the moment.
Thanks very much, Sharon. I appreciate you bringing up those points. Like, even if there's not technically a wait list for clinic services or medication, the hours of operation, Monday to Friday, and the intake process can be such a barrier for folks. Having that kind of treatment when and where people need it could be so important. Bruce, would you like to share next some reflections on flexibility in opioid use disorder treatment and putting it into practice?
Thanks, Tommy. Yes, I would. It's essential from the lens that I see that we be patient focused and patient centered. A lot of times I use telephone to start initiation and allow the circumstances that surround the patient depict whether or not we start talking about carries. I'm around long enough to know that when they first put this drug on the market, they were talking about having no such thing as carries, because carries is a methadone term, not a Suboxone term. And so therefore, I've always worked from the point of view that you meet the patient where they sit or where they stand or where they work. And I've often given 3-month supply to send somebody away to the Alberta or to the coast of Africa so I keep them employed. I wouldn't dream of doing that with methadone. So it's very reassuring to me more than anything, because the practice that I've always been doing is I start very, very quickly with getting a person out the door with as much product in their hand as I can. And often the first day I have started with giving a weekly supply. So in essence, I think this has just been more reassuring for me than anything else.
Thanks very much, Bruce. I do want to talk about how the last 2+ years of our experience with the COVID pandemic and how that's changed the treatment landscape, our health system has affected caring for people with OUD. And so maybe at first I'll go to Dan and ask, what has your experience been like during the COVID pandemic when it comes to opioid use disorder care? How has this impacted people in your practice or pharmacy setting? And what are some of the approaches and practices that emerged that you find effective, and maybe some that you haven't found as effective? Is Dan on mute? Are you still with us? I can't hear him. Can others hear him? No. Okay. I think he is in the pharmacy today, so maybe he's going to come back and join us. But so Sarah, maybe we'll start back with you. How have you seen things change during the COVID pandemic, and what do you think are some promising practices we should try to maintain when it comes to flexibility?
For sure, there's been a lot of flexibility that's been really, really great to have. I think one of the key ones for being able to be rapid is allowing verbal ordering.
Hey,
in
I'm
some
back.
cases. Oh, there he is.
Sorry, I am in the dispensary, so I'm kind of trying to do 2 things at once here. So I've got my watch going off, Sarah calling me, telling me I'm on. So that's my cue. So yeah, just I don't know what you covered, Sarah. Sorry, I had to.
No, I just started to talk
sec.
about. I was just starting to talk about verbal ordering, and that's all I got in. So you can take it over.
Okay. With COVID, you know, the class exemption around controlled substances for me and really for our patients made a world of a difference with our capacity. You know, Sarah alluding to verbal ordering scripts. You know, we'll often do things, you know, back and forth via text or verbal, which allows a lot of flexibility in adjusting dosing. So that was a big help. Transferring prescriptions was another one from a regulatory standpoint, not needing to, you know, get a new prescription generated every time a patient needed to, you know, whether they're going away for a weekend or working, you know, at a province. It gave a lot of flexibility around that. And for us too, so we had a satellite IO clinic up here in Fredericton for a period of time. And part of that practice, I actually had the nursing staff giving meds at that site. Just I couldn't be in 2 places at once and didn't have the capacity to have pharmacy. Originally, you could only apply for a class exemption through Health Canada in more rural areas, First Nation communities. This allowed for nursing to actually do med pass for controlled substances. So that gave us the ability to do, you know, our overnight Cadian methadone, Suboxone for other patients with nurses doing the med pass. So it didn't necessarily have to be a pharmacist on site. So just a few examples of how COVID kind of changed the regulatory environment around controlled substances, and they've extended those exemptions, I believe, until 2026. So the hope is that those will remain in place, because truthfully, I can't fathom going back to not being able to take verbal orders, not being able to extend prescriptions on Suboxone for patients that are stable. Yeah, so those would be kind of some of the top of mind things that have impacted pharmacy practice anyway.
Those are some great examples, Dan, and it seems like, meeting need in the moment and then recognizing that all these kind of more flexible patient-centered care practices can be safe and are improving people's outcomes, all in response to the public health crisis. But thanks for sharing those experiences. Do others on the panel have thoughts about how treatment has changed during COVID with flexibility in mind and some of the practices that we're hoping to continue to carry forward?
I can certainly jump in here. It looks like Bruce is also off mute, so I'm sorry if I'm butting in. I just wanted to just highlight a couple things. And, Bruce talked about being able to call people. Virtual care has certainly been an essential component of a change that's really led to huge amounts of accessibility. As I was mentioning, we have people rurally here. We have one of the Indigenous reserves that's upriver, about an hour and 45 minutes. We have a group appointment there. In fact, we're going to have it this afternoon after I'm done here. And there's roughly, about 15 people that are on OUD, not IOT, but they're on OUD. And there would have been no way that I could have done that on a regular basis and have people, sorry, I have to cough, have people get rapid access, be able to walk in. And the LPN staff up there, they see somebody, they do a rapid dip. And like we have this whole process in place. And then we can get a prescription sent off ASAP and be able to continue to follow up virtually. So I think that probably has been one of the most amazing components. And just again, the flexibility, all the pharmacists have my cell numbers, so I get texts here and there and I make myself available. That's fine with me. But then I can just get back in touch with them really quickly. It just meets people where they're at. And I feel it'd be really good to have someone actually drill down and get the data for sure. But it feels like people are retaining and programming a lot more. And it's interesting with the Suboxone in particular. This isn't so much COVID, this is just getting back to the first question. Having the ability to have take-home doses really quickly. I feel like a lot of the people that have that are adhering to our program, coming to the group appointments and engaging in care, and just meeting people where they're at seems to really engender that this is a collaborative process that we're going through together, and it helps people feel a lot more empowered. So I'm enjoying that.
Thanks very much, Sarah.
One of the things that I found was telehealth. Being able to access people through telehealth, through telephone, and Zoom and other methods was hugely convenient. It has its drawbacks, but overall, I thought I was able to treat the part of my practice that's chronic pain and addiction were better serviced by me being able to do that, and a better buy-in than I could before. The other thing that I found immensely, and I agree with everything that's been said so far, was the pharmacists were really open, speaking my secretary, and that didn't pull me away from all the time. And there was no issue with me signing a slip and sending it over to them and having it done. So I found that to be much more. And we looked at the death data coming out, because after we wrote for the College of Physicians and Surgeons, the guidelines, we then followed the death data to see whether or not we were causing any issues. And we didn't see any increase in deaths that we could attribute to Suboxone. That's it for me.
That's great, Bruce. Thank you both, Sarah and Bruce, for more powerful examples of what can happen when suddenly, our what's the care that's needed changes, and we're trying new things and find out that being more patient-centered and flexible can be safe and much more effective. The last section of our panel discussion here before we get into questions from the audience is about what we need to do next, thinking about the future, trying to improve access to treatment, support people to engage and adhere, support people to stay in treatment if they want to, and improve outcomes. What are the next steps for expanding flexibility in care for people with OUD in Atlantic Canada? And maybe first I'll go to Sharon, perhaps with that nursing perspective that you're bringing, or not specifically, but what do you think we need to do next to make things better?
I think from a nursing perspective, and that's a great question, because I really love how people have given examples already, how they're maximizing scope of practice, they're using virtual health and telehealth. And I see that as not always happening from my lens, working on a street level, seeing people walk in every day and saying they'd like to access OAT. They don't have a phone. So I would really like to see people utilize spaces that are already engaged with service users to connect with. I know we talk a lot about privacy and confidentiality and circle of care, and sometimes that is a barrier to being more collaborative. But I see that nurses are gatekeepers, and there's no nursing positions really that exist anymore where you're not, really well positioned to advocate for someone that may be in need for some type of OAT. And really the future needs to expand the options, because sometimes I see people who are really struggling with the retention and with maintaining their participation in OAT, because we don't have, the injectable option here. It doesn't exist. So sometimes people struggle with this when really they need that. And I think that's a real barrier to retention rates, honestly. So it's one thing to be able to access it in a timely manner and use all these, virtual forms, which I think is great. I could be, we do it in the other capacities, like if I'm doing wound care, if I'm doing antibiotic treatment, I just connect with physicians, and then I'm with the service user, and together we work it out. We can have Skype or we can have telephone, and we get the job done. But I sometimes see that isn't happening as much with OAT in the eastern part of, say, Nova Scotia. It is in other parts, but in the more rural urban parts, it's not available. But I just see nurses as being pivotal to be advocates and like I say, gatekeepers, and negotiating that with the healthcare systems and trying to change policy and work towards that.
Thanks very much, Sharon. Those are some great examples. We have a couple more minutes before we get to audience Q&A. Do others on the panel have thoughts about where we go from here and how we make things better? We've already heard about some great innovations happening, but where to next in terms of improving care and making things more flexible?
I'll take a stab at it. There's two things I would like to see more of. I'd like to see more involvement of lived experienced people who have made the grade and are doing well, become involved in frontline care, and for the governments to become involved to pay people jobs to do that, so that they're more intricately involved and can show a pathway. This is not necessarily as hard as some people make it out to be, or not even as scary when you've got a comrade there to lean on to help. The second thing I'd like to see a lot more of is mentorship. I'd like to see mentorships set up not only for nurses, nurse practitioners, physicians, pharmacists, but also for people to have the people with lived experiencing be involved in their mentorship, so you can show just the effects that it can have and the benefits that you can end up getting from this. Those are two comments I wanted to make.
Yeah, those are great examples, Bruce. I think paying people with lived and living experience for their expertise in terms of being experts to help make the system better is incredibly important, and including people who aren't using OAT and aren't benefiting from it, about why not, and listening and learning about how to make the system better serve their needs as well, because that's one of the major focuses of our discussion today. I am mindful of the time, and we've already had some great thoughtful questions in the chat. So first, I'd like to raise a question from Christopher Smith about this idea of flexibility between treatment models and medication options. We've discussed methadone and buprenorphine naloxone, but they're wondering why there's only one injectable OAT program in Atlantic Canada, which we've heard about today, Riverstone Recovery. And are any OAT programs in Atlantic Canada using diacetyl morphine or hydromorphone? Maybe Sara, you could quickly give us a rundown on Riverstone's care model, and then we could hear from others about why that hasn't necessarily been taken up elsewhere, or how we could change.
I definitely appreciate the question and the urgency. behind it. So as at Riverstone, what we have is we do have injectable hydromorphone. So that's what people are injecting 3 times a day or up to 3 times a day. And then we give them a long acting overnight. Usually it's Cadian, but it can be methadone. We have the odd person who doesn't really want anything for overnight, which is fine. It's not that they're odd, sorry, like some people. We have another IOD open in St. John. We're looking to open one in Moncton. And I know these are just the big cities. My hope over the next year or so is I've already had meetings working with the government within Horizon Health, which is our local health authority, to start a discussion about every community health center or every center on any of the reserves. Those are the doors that should open, like Sharon was talking about. The people that are on the ground working with people, like there should be a no wrong door approach. Someone walks into the ER, they could get started on treatment. You know, we should really be looking at what are all of the natural spaces people go to and provide care there. My hope is through the work we're doing at Riverstone is we're developing a ton of order sets. Like we're making everything very manualized, as much as we're obviously a cool environment. This is our first IOT room I'm in right now with our beautiful mural, but we try to have it be as evidence-based as possible and then easy to roll out. So it's rapid access. It's really predictable. People know what to do and they know how to put it in place. We are LPN run. For the most part. I mean, I'm the medical director. We have a nurse manager who's an RN who's becoming a nurse practitioner, but everyone delivering care day to day are LPNs. And we even now have some PSW that are trained in acute care that are working, not so much they can't handle the medication, but they could be monitors in the IOT room. So we're trying to figure out how do we deliver this as rapidly, as expeditiously, as affordably as possible, so that we can then say this is a model that could be rolled out. Again, I would love everywhere in a little tiny town that has a community health center, there should be an IOT. I mean, I would love that. That's looking at a medical model. There's a lot of discussion nationally at looking at a non-medical model, more of a community model, which would just be safer supply for whoever needs it whenever they need it. So there certainly is a lot of discussion about that. So I think there could be a spectrum of arrangement. And I believe that, I mean, that's part of the committees that I'm sitting on, is looking at how do we deliver that type of care rapidly that isn't necessarily medicalized. So I guess it's unfortunately still taking time for us to shift into that. Some of the barriers that do need to be addressed. So you asked about diacetylmorphine. We're not using heroin out here because people didn't really have heroin as a first option. That mostly hydromorphone is what people are wanting in the New Brunswick region, especially. I think Halifax maybe has had maybe heroin here or there, but in general, it's much more so diacetylmorphine is a more out west. And I guess the other important part to note is that some of the barriers that exist in some provinces is they don't have the potency of hydromorphone that needs to be. So we have 50 milligrams per milliliter is on our formulary in New Brunswick. And it is in Nova Scotia, thankfully, and I bet it's not necessarily in every province. So we need the feds to sort of mandate that maybe across the board, because there's about half the provinces don't even have access to an injectable form. There is the hope, I think some people want to have liquid fentanyl be an option. It's not so much right now out here. Fentanyl is not covered under the formulary for injection at all, except in a hospital setting. So it would be challenging. You also have to inject it a lot more times a day. So the risk of injection into the skin, but again, it's meeting people where they're at. That may come. I think it's more likely to be out west that it would come more rapidly. So I think that I feel the urgency. Also, the Overlook in Dartmouth is a new IOT starting. So we aren't the only one anymore. So there is one in Dartmouth. But again, my hope is that we can roll out a model that could be adapted in a lot of different medical settings. But there still are barriers of stigma, to be honest, and the different health authorities have to recognize the urgency as well.
Thanks very much, Sarah. That was a really thoughtful response about kind of different levels of people involved in these clinics and what can and can't happen, and just appreciate so much your innovative work and leadership in this area. I do want to follow up on Duncan Webster's question about how people are approaching take-home doses for buprenorphine and methadone, because it is so relevant to the OPTIMA trial and our region here in Atlantic Canada. But before opening that up to the panel, I just want to acknowledge that some people in the chat have been sharing their experiences about feeling stigmatized in healthcare settings, especially while getting treatment for opioid use disorder. And I want to thank you for sharing those experiences and acknowledge how important that is in terms of flexibility, being patient-centered care models. We all need to do better in terms of reducing stigma and making it a safe as possible experience to come and receive care. So thank you for pointing those out. So to address Duncan's question, does anybody have thoughts on what standards are in your current setting or in your clinical practice about considerations around take-home doses for buprenorphine or methadone or other options?
I guess I can speak again. So in terms of Suboxone, it's really rapidly, like again, once someone is sort of has their induction done, we will go to weekly carry doses, except again, if someone's at high risk of being exploited by people in their immediate surroundings and we're afraid for their safety. Whenever it comes to methadone and Katie, and I must admit, we try to be a little more flexible, but it's just the concerns with methadone and the safety profile isn't quite the same. So there's a lot of the art of medicine that comes in there in that decision making. We don't do urine drug screening anymore for just routine monitoring. It's mostly if someone is wanting to work towards carry doses, as we call it, work towards carry doses, that we will engage in urine drug screening just to see if there's any severe polypharmacy or any other concerns around safety with methadone in particular. But if someone is going to work and, you know, with Bruce, that's awesome, people going away to work, you know, we do try to be as accessible as possible to really fill in their reality and support them as best they can. So we will go to earlier carry doses or try to be flexible, but it doesn't feel quite as safe. And so, but at the same time, if someone is accessing another illicit substance because they just can't get to the pharmacy all the time. So there's so much more ambiguity around that. Again, Suboxone, the lovely thing is like instant safety. Feel super happy about that. I will though still work with people where they're at with the Cadian and the methadone just to see, you know, what can we do from a stimulant use disorder treatment. We will also often, if someone wants to have carry doses or would benefit by that, we do go to Concerta relatively quickly. I know it doesn't have the same, it's very off-label treatment at the moment, but that's also another safety version, just in case people are seeing folks on stimulant use disorder pathways, that that also, those two together, we have a lot of people on that combination. I don't know if that fully answers what Duncan was looking for. But
Thanks very much, Sarah.
You know, from my previous statement, you know what my thoughts are. I meet the person from where they are. I think we have to treat people as people and not as disorders. I think it's very important when we're moving forward here that, like for urinary drug testing, we have to have a reason to do a urinary drug screen. It's no longer acceptable to force somebody into a bathroom that has been prepared for them when there's so many other indices that we can use to determine if a person is doing well. I mean, having a person being abstinent is not necessarily the goal of treatment. The treatment is have the person functioning well in society. So it's not, you're not trying to eradicate a disease. You're trying to help a person get back to where they have some dignity in their lives. So for me, you know, I agree with what everyone else has said, but we should be looking at giving people what they need from where they are. And if they need one witnessed and 6 days, day one, then that's what you do.
Thanks very much, Bruce, and everyone for sharing those thoughts. I believe some of the panelists can stick around for another few minutes, but I'm just mindful of the time. We're coming up to the hour. So for those who do need to sign off now, thank you so much for joining us. Thanks again to our presenter, Dr. Sherry Stewart, and all four of our panelists. We really appreciate you taking the time to share your experiences, all these practical examples and strategies, and learning about your passion that you bring to this work. We would really appreciate your feedback to help us improve this sessions. You'll receive a questionnaire by email. Please fill it out if you have a moment. There's an opportunity to win a $50 gift card up for grabs if you complete the pre and post questionnaires. So thanks again to everyone who has to sign off right now. For those who can stick around for a couple more minutes, we have anonymous questions submitted. How can we improve collaboration among healthcare providers? I presume kind of in different professions or all involved in caring for people with opioid use disorder. How can we improve collaboration among healthcare providers to optimize patient-centered care? For example, agreements among healthcare provider on the safety profile of buprenorphine naloxone to facilitate early take-home doses. Any thoughts on how we could improve collaboration?
I guess I'm not really certain about the collaboration, because from my lens, when you're trying to collaborate, you're really trying to get somebody connected with, you know, OAT or whatever the case may be in terms of starting a medication. It would be nice to see that, you know, we seem to be having a lot more in Nova Scotia, for example, collaborative practices, urgent care centers, you know, we don't have a lot of family practices or primary care physicians starting up, but we have a lot of these collaborative centers. But in the eastern part of Nova Scotia, at least, none of those offer any form of OAT. So it is, well, like Bruce said, and everyone else, it's not client-centered when they have to go here for OAT, here for primary care. Most of them don't have a primary care physician. That's just because you have OAT doesn't mean you're connected with mental health and addiction. So it is, you know, that wraparound or the one-stop shopping model that we see in so many other places. It's just, and, you know, with peer support and all the other nursing support and all those other social determinant supports. I mean, that would make collaboration kind of more of a organic. Was right now you are trying to always get people connected to 3 or 4 different services to meet really, you know, we're not really, you know, well suited to we're not flexible, I think, as healthcare systems, or we're pockets still, but people are people, and they it's hard for them to navigate, as always. So I think offering it at all these primary locations, like, you know, urgent care centers, collaborative care centers, we need to have inductions happening. We have a lot of experienced pharmacists that can collaborate and are really located in all even our little more rural areas that can make this happen. So they are your primary, you know, backbone to most people that are prescribing OAT, because gone are the days where we had to administer each dose on site or whatever the case may be. And I like Dr. Martel's comment there about, you know, let's stop talking stigmatizing take home takeaways, you know, it's dispensing intervals. You know, any suggestion to bring stigma away from some of the language we use is fantastic. But the collaboration it's a struggle for me every day, trying to bring all these care providers together for one person and all the communication that goes with it.
Thanks very much, Sharon. So some need for improved communication among the services that do exist, some need for rethinking those services to actually integrate what people need, more of what people need under one roof, and then more need for care navigators. It sounds like especially people with lived and living experience as care navigators at the same time.
Yeah,
does anyone else?
Tell me if I could add
about that.
First. We also, we know what this is about, all right, you know, and I agree with Dr. Martel in saying, you know, the language, but there's a whole majority of people within the healthcare who don't. So if we don't start eating away at their biases and getting them to understand what harm reduction is, and getting them to understand that this person is not going to come in and shoot them to get to get money off them, you know, they have to be treated as people, and we have to get that group to know, you know, when someone comes into emergency, they have to be treated as a person. They don't be treated as a disorder, and having had comments make on like I can't get your IV, so I bet if there was a hit of acid on it, you get an IV. You know, it's though that type of thinking is very deleterious to the individual, and it sets them back, you know, years in their recovery. So I'd like to see more and more inroads being made to the rest of the healthcare to be able to understand what we do and what we go through and what the individuals do and go through.
So some collective advocacy from those of us who are involved in this work across the aisles to our colleagues. That sounds like still needs to go a long way. I see Dr. Allen's hand raised. Maureen, do you have a question? I think we still have a couple more minutes.
Yeah, I think it was just building on what Bruce was saying, that so my background is emerge and palliative care. So you integrate the access to these resources actually in the spaces that you're in. So what you're doing is teaching your colleagues that this is actually quite normal practice, and it actually allows us to see the individual truly the way they are, rather than in a state where they're really not able to kind of engage with us. And so I think it's the environments that they're in. I just want to actually turn the tables a little bit around the injectable, just as a palliative care physician. So I strongly encourage actually injectable opioids as well for the management of opiate use disorder. But I think the reality that we have to realize, especially nationally, is that the access to parental opioids has been hugely impacted, not from an opioid use perspective, but just in general in terms of supply and consistency. So as a palliative care physician, there are often times when I don't even have access to parental opioids. I'm switching around constantly. So I think working collaboratively within the different disciplines in terms of ensuring safe supply as well as a consistent supply, I think is really important. So I just want to put that out there as well.
Thanks very much, Maureen. We had another question in the chat. Alyssa, Cynic's House, if I'm understanding correctly. They are working in a practice setting where rapid access practices, or I'm imagining kind of like same-day starts or treatment on demand, has been reduced, and administration's not supportive of it. Do folks on the panel have any resources or information they can use to challenge this? And it sounds like some advocacy resources as well, to try to change things in their practice setting. We talked a bit about the need for kind of more communication and more collaboration and a need for advocacy, but do folks have specific strategies or resources we could point to start to support people making these changes in our region?
I'm just thinking a little on the fly. I mean, in terms of showing like outcomes or publications or that sort of thing, then there certainly would be some out there. But I guess what I have found mostly, and I appreciate, issues with the ER, like Bruce was talking about, the barriers people will experience, and some of the folks in the chat talking about their traumas. The one thing I have found that we're trying to do at least is have open conversations to find out what the fears are, what the concerns are, and then just try to address them with, at least we're showing what our immediate outcomes are with Riverstone. But with Crosstown Clinic, there's probably likely some literature just even from the original trials around IOT and the justification for those. European studies into IOT for many, many years can probably show some positive outcomes, but I guess it would be understanding what the fears are, because, until then, any amount of literature is not necessarily going to address what people are experiencing. So it's finding out what their needs are, what their fears are, what they're picturing the worst outcome is, that sort of thing, and then really kind of trying to address that. Riverstone, we're more than happy to do tours. We've done virtual tours for lots of different people and collaborated as best we can. So we're always a resource if people ever want to reach out and talk to us. You can just Google Riverstone Recovery Center and there's a contact us link pretty easily. But I think it is really elevating our voices to the places that will listen. And I know in the RER, there's a lot of fear whenever they see, they just, and I guess I've tried to take the tack that they just feel helpless and don't know what to do. And it's turning into anger and frustration with the person in front of them, but it's coming from a place of helplessness or fear. And so I've tried to say, we are a resource. We want to help you understand what's wrong. These are things that we can do to try to help you. So a lot of it is coming at it as best we can from collaborating with our colleagues, even if they're afraid, and just try to bring them along so they realize better things will come from actually working in this way.
That's great, Sarah. Those are really thoughtful suggestions. We're coming up on 10 minutes past, so I think it is time to bring our session to a close. I want to thank the presenter and panelists again for their presentations, their thoughts, and for sticking around for a few more audience questions. Thanks again, everyone in the audience, for joining us. And another reminder to please fill out the post-session questionnaire with $50 gift cards up for grabs. Hopefully, Atlantic Canada is a relatively small place, even if a large geographic area. We can continue many of these conversations and continue to support each other to to make things better. So thanks again, everyone. Have a great rest of your day.
Tommy, great job.
Oh, thank you.
You did
Yeah,
well.
excellent
As
moderation.
always, Tommy.
Oh, it's very kind.
I'm impressed. Well done.
Oh, wow. Thanks for all your thoughts, everyone. I know I was putting people on the spot sometimes, so I really appreciate it. Lots of different perspectives.